So Trishan, thank you for driving all the way down from Boston to
Thanks
talk
for
to my
having me.
students today. It's so fun to have you here.
Thank you.
And you're the perfect person to talk about this topic today, about financial viability, because I know that you as an entrepreneur have been driven by changing things and improving things, and yet you believe very firmly that you need to have financial viability to do that, and that you have to find a theory of change that someone's willing to pay for. And so I'd love it if you tell us a little bit about your experience as an entrepreneur and your journey in finding financial viability for your ideas.
Yeah.
The way I've explained financial viability in this module has been finding a revenue model, like who's going to pay, when, how, why. And also like a distribution model, are you going straight to end user or through a partner organization? And then regardless of your model, like internal operational efficiencies. Like how can you design this in a lean way? So anything that comes to mind in terms of how those played out in your journey, or other stuff? Am I missing anything?
No, I think that's an excellent question. So there's a lot there, right? So I think, my experience here is, I suppose in two parts. So there's two problems that I experienced of the nature that you're describing.
Okay.
So first the first like decade of my career is spent as a clinician, and we were running clinical services. And the thing that we found—
You were a primary care physician, right, in the UK?
I was a primary care physician in the UK. And so, like a lot of the issues there is that, well, I think in the UK we've done a lot of work around protocolizing care, task shifting, getting more team-based care, stuff that's like fairly kind of commonplace here now. Just because of the way that the health system was set up. We were doing a lot of that a while ago.
All the operational stuff, right? How can you make it more efficient?
All the operational stuff about how you get exactly. So you kind of get the most leverage you can out of the clinical team that you've got.
So even as a doctor, you were like an entrepreneur. Like how can I improve outcomes, lower costs?
Yeah, I guess so.
Right?
And I was certainly by no means unique in doing that. So like there was also a lot of people doing it. But the thing that I found that was problematic is that none of those things really scale. And I remember when we were like looking at all of the practice accounts and seeing how we've done this year and projecting for the next year. And we were in a federation of doctors managing about 100,000 lives in London at the time. And we had like a set of that was just our practice was responsible for managing. And it was very clear that if we wanted to increase that number, say from 10,000 that we were managing to 20,000, we would have to have double the amount of buildings and double the amount of staff, and there'd be some efficiency, but it certainly would still be like a large amount of capital outlay to like keep increasing. And there was effectively this linear function of like, if you wanted to serve more patients, which was the aim, we have something a care model that we believe works, but so surely we wanted to get it to as many people as possible. We would have had to like, scale the resources in exactly the same way that we look to scale the impact.
So you needed to change the model.
Yeah, exactly. So that was challenging. So we knew that like, whereas like in-person care or like visit-based care or the traditional health system, there is a reasonable kind of revenue model or like business model around that. But it's actually very difficult to scale it. So even though it's like financially viable, arguably, it's actually very difficult to get to any scale. So then the second half of my career, I suppose, was has been in technology. And in that situation, I started off working, I'd studied public health, and we set up this non-profit student group at MIT. We were developing technology for community healthcare workers in developing countries, actually. Open source, free software to upskill community healthcare workers and put them into like a virtual network using technology. And there we found that like we had something that could definitely scale. We could take those same protocols that I'd used in clinical practice, put them in software, and now if we wanted to go from 10,000 to 100,000 patients, we could do that just by having more servers, and there was some costs associated, but very, very modest compared to, so we could increase the number of patients like this and increase the cost like that. Really, really attractive. But the problem with that we found, kind of speaking to your point, is that we didn't have a model whereby we were creating more resources than we consumed. i.e. like, this was is free software. It's still running, actually. It's still available. Okay. It's still run as like a student group at MIT, and there's a
What's it called?
It's called sana.mit.edu. And there's like been, I left many years ago, and there's been many people working on it subsequently. But because we didn't have that thing, we were creating a ton of value, we felt, and the software was going out there being implemented with patients and clinicians around the world, but that value that was being created was not in any way kind of flowing back to the organization. So we were getting grant money to like keep creating this value, putting it out there in the world, but none of it was kind of coming back to the organization, which actually was the intent, the explicit purpose of what we were doing. I guess the third act, what led on to Wellframe and all the other stuff I've done subsequently, is what we really experience in a very tangible way. If you have a model like that, you can get things to scale. So it's like better, quote unquote, than the kind of typical clinical way of doing things. You can get to many more patients, you can have much greater clinical impact. However, the problem is like, unless you have like some kind of business model or revenue model or some way of that value that you're creating and putting out in the world, some of it flowing back to the organization, you can't keep the kind of talent that you need to run these kind of organizations, because they're also, you know, they have to pay rent and they've got certain expectations of their lives. They want to go on holiday, so they're going to go and work in the tech industry or go and work in finance or go and work in consulting or any number of things that like highly skilled people do. So the problem that you're bringing up here, like that's how the rubber meets the road very, very tangibly. So the set of work that we've been doing subsequently is like trying to figure out like the synthesis of the two former kind of approaches, I suppose. Trying to find what works clinically, trying to use technology to scale it, but then having some way where out of that value created, some of it is like captured and shared between like the patients, the clinicians, the organizations that they represent, and also some of that flows back into the company such that we can reinvest it to generate further growth. And
that was the idea for Wellframe,
That was the idea for Wellframe.
Okay, so before we talk about Wellframe, I want to just press pause and say one thing. Or two things, like, because you've already talked about two different financial viability models. The first one is like, how can you improve government outcomes or existing outcomes of existing health systems? Like you can improve them, but it's not really innovation. Like it's a linear path.
Well, I mean, I think it's innovation, but it's not necessarily that scalable.
Okay, so it's not scalable. It's less scalable when you're doing it in that linear correlation, like more buildings, more doctors, whatever.
Exactly,
And then the second one is a more scalable innovation, but there's no like revenue model coming back to you. So it works in a nonprofit model, and that's how it survived in university. It's grant-based. There's students working on it. And the third one is a for-profit model. So tell us more about how that worked.
So then, I mean, we felt really strongly after having worked in the research context and seeing like really world-class talent, and you know, like people have gone on to lead technology groups at like household name things. For people watching this, they would definitely have used the software made by the people who were originally working in this group, because they've gone on to lead the engineering teams at leading technology companies. But like we wanted them to work on these healthcare problems, and it was very difficult. There was just no way we could like. There was no proposition that, you know, there's only so far you can get with relying on people's kind of altruism.
You mean the MIT students?
Well, they were students at the time. So we felt with Wellframe that like, well, we wanted to create something whereby the value that we wanted to create was pretty clear. Well, the clinical need was clear. We were interested in chronic disease management. It's a key source of like variance in long-term health outcomes. We basically leave it to patients to do it themselves. So it was those people that we felt they're the ones that had the most acute need, and where there was like the clearest financial value proposition to the sponsoring organizations.
And who are the sponsoring organizations?
So we started off working with provider organizations, so hospitals, and then we shifted into working more with payers, with health plans.
Like insurance companies?
Insurance companies. In fact, all the leading insurance companies in the country. All of the commercial plans, the ones that people get through their employer, and the Blues plans, and the Blues Venture Fund actually invested in the last round we had before the acquisition, and a large network of Medicaid plans. And so we were kind of working with them so they were ultimately bearing the financial costs of ill health, and they had staff who were tasked with providing services to patients who had these complex needs that we described. Because if you helped those people, you could really make a difference to their lives and also some of the healthcare utilization. So there was kind of a financial incentive for them to engage with this kind of work and push it to patients. So it was always free to patients. That's what we were kind of free to patients and clinicians. So then there had to be a sponsor.
Yeah.
Right?
So you're designing this for the end user who's the patient,
Yep.
but then they're not paying, their insurance company
Yeah,
is paying.
exactly. It's paying on their behalf. So the patient and the clinician are like the end users. So there's kind of two parts to the software. There's a patient mobile app and there's a clinician dashboard. And so they have like two end users, but neither of those end users pay, even though both of them.
So there's three
considerably benefit.
stakeholders: the healthcare provider
Yep.
and the patient, and then the insurance company.
Yeah, effectively so. Yeah, exactly
Okay.
right. Yeah.
And how does the insurance company convince the healthcare provider, like the clinician, to use it? Like, who's the decision maker?
Yeah, so there's basically two kind of models for that. One is that most people don't know actually, but health plans have their own staff of nurses doing care management for these very complex patients.
Okay, got it.
And it's kind of the way insurance works in general, actually. Like, you have a few people with very complex needs, a lot of people who are very well and don't, really need that much, and you're basically cross-subsidizing, right? Like, all of the people who are better off are paying premiums, and then there's some people who are paying premiums as well, but they're having many more, their cost of care is much greater than their premiums, but it's subsidized by the other people. That's the general insurance model. And so health plans understand that those people who have the very complex needs, they probably just need more help, kind of like a concierge almost. And so so that model exists.
And they'll save money and the patient gets healthy.
Exactly. So that's the plan. But they were using kind of, I guess, the last generation of technology, the telephone, basically, to phone patients up. So we were just really kind of taking that and bringing it up to date.
That's amazing.
Yeah. So that was it. That was 10 years of work. So I have to say, for the record, I'm no longer at Wellframe. We sold the company, and I don't have any kind of managerial responsibility. Yeah, thanks. But it's still going on.
Yeah.
It's still growing. But I guess, yeah.
How did you start up and get the funding and all that?
Yeah, I think there's you have to have a bias towards action, and I think that's kind of just a core part of the DNA here. And of course, there's some things that require, like, for example, I don't know, if you had an idea for like a vaccine, it's very difficult to get very far without some serious funding. Whereas the beauty of software certainly is that, theoretically at least, anyone can learn to code to a degree, or actually using a lot of no-code tools that are available these days, no-code or low-code, which is like a movement that's really only taken off in the last 5 years. You can get very far without any financing yourself. I think the really implicit in this question, though, is that I feel, both on the investment side as well as kind of doing it myself, is that people who are doing what they would do for free anyway are much kind of better entrepreneurs or better people to back than those who are kind of looking and waiting till there's some kind of funding or compensation to do something. So I think what other test is there of someone's motivation around sticking with an idea for 10 years and pushing to get it done, than that they'd be willing to do it for free themselves and do whatever they can with their time. They call it hustle and all these kind of things, but that's basically what it is well, all I've really got, the only resource I've got to invest into this is my own time and skills, but I believe in it so much that I'm just going to do that and see how far we get. So I think the best ideas and the best teams will do that. Unfortunately, that for some reason I don't really fully understand is the minority. Maybe the reason is just the opportunity cost, especially the more educated you are, is just higher. You could get a normal job that will pay you some money to do some stuff.
Yeah, or you have to hold down 3 jobs to feed your family and you don't have time. But I do see examples of it even in low resource grassroots movement. The people, if investors, whether philanthropic funders or venture capitalists, are looking for the people who are already doing the work, even if it's in low resource grassroots setting, you have community leaders who are doing the work, working for change, and that's who you invest in, whether it's financially viable or not.
No, that's right. That's exactly what you're looking for. And I appreciate the stuff I'm saying is coming basically, to be blunt, from a very privileged point of view, right, where you can have these different choices. For many people, they're if they're choosing between immediate survival or coming up with some tech idea that's going to take 10 years to develop, you should definitely focus on the former. It's not And yeah, the world is not fair in that regard, and there's some broader kind of asymmetries that need to be addressed to get
For sure, but the bias towards action is totally in line with the theme of this course. Like whatever you can do in the context of your own life and the resources you have access to, just do it and like get the movement started.
Yeah.
Thank you so much,
Right.
T.
Oh, no worries.
Thanks.
Thanks for the conversation.